Welcome back, everybody, to another WVEMS protocol rollout. Today we'll be going over all the new updates for 2026, and I'm joined by
EMT Brian Alderson,
Dr. LaPera,
Dr. Stanley,
Dr. Green.
and I'm Dr. Ike.
As always, the first step will be to update your app.
So check the App Store, make sure that you have the newest version.
Once you have the new version, open the app and click the menu to choose the new protocols. Sometimes it takes a few days for the new app to propagate through the app stores, so if the new update is not immediately available, you can always use the PDF and then try again later.
And remember, last year's protocols will still be available in the app for you to use until you're cleared by your agency for this year.
Today, we'll start with some formulary updates,
And then we'll review some EMT updates.
and later we'll cover updates for AEMTs and above.
And then we'll finish with the latest critical care news.
As we all know, last year Virginia Office of EMS retired the statewide system of drug box exchange. So Western Virginia EMS now publishes a recommended formulary to go along with these protocols each year. You can access the formulary in the app here on page 118 or from the link below.
For 2026, there are only a few changes to the formulary. Baqsimi has been added to the optional formulary list at the EMT level for agencies that wish to carry it. And IV Toradol has been included at the AEMT level for pain. We'll discuss these meds more in a minute.
Other minor changes include increasing the suggested amount of atropine to match the new AHA 2025 ACLS recommendations. We've also removed thiamine after consultation with the state regarding scope of practice.
And you'll notice some other elective substitutions are listed, including morphine, Ativan, and succinylcholine. Individual agencies might choose to use these substitute meds with a custom protocol from their OMD. But the standard protocols will continue to use fentanyl, Versed, and rocuronium.
First up are the EMT updates, which comprise about half of the 2026 changes.
We will also review all the specific VA OEMS red dot skills found in the WVEMS protocols.
This will help us maintain compliance with current Virginia Office of EMS regulations.
In protocol number 4, airway, Heimlich has been replaced by backblows and thrusts. This is the first of several updates from the AHA 2025 guidelines that were just released in October.
Providers should start with 5 back blows or slaps for any patient that is choking, even adults. Providers should then alternate 5 standard abdominal thrusts with 5 back blows for most patients. Providers should use chest thrusts instead for babies or very obese adults or pregnant patients.
Biad remains our primary airway, and WVMS endorses the iGel for all ages.
Biad is an OEMS red dot skill. So if you have any questions or if you're a new provider, contact your training officer.
In number 6, breathing, providers should remember to remove any chest seal if providing positive pressure ventilation. Positive pressure may include NIPPV or the BVM with any adjunct.
Non-invasive positive pressure ventilation includes both CPAP and BiPAP.
It is appropriate to use non-invasive ventilation on less responsive patients, but monitor closely and remove promptly if any vomiting.
Capnography remains important in our breathing protocol. It's an important adjunct that helps us diagnose and treat respiratory complications.
Recall in 2025, the entire book was standardized, and all end title targets are now 35 to 45 for all ages and indications.
NIPPV and CAPNO are OEMS red dot skills, so if you have any questions or you're a new provider, contact your training officer.
Our first new med of 2026 is found here in protocol number 38, diabetic.
Agencies may now choose to carry intranasal Baqsimi as an alternate way to administer glucagon in hypoglycemic emergencies. Providers should note that the formulation and dosing for Baqsimi are different than the classic intramuscular glucagon.
It is not appropriate to use the classic intramuscular glucagon for intranasal dosing. The Baqsimi inhaler is pre-filled and contains 3 milligrams of glucagon for intranasal administration.
Baqsimi is included at the EMT level for any patient 1 year of age or older.
As with classic intramuscular glucagon, providers should use caution with any refusal.
Improvement is only temporary, and patients will need additional glucose support after any improvement with glucagon.
Unfortunately, Baqsimi is rather expensive, so it is included on the optional list for interested agencies, but it is not required.
Baqsimi is a new medication, so if you have any questions or concerns regarding glucagon or intranasal administration, please contact your training officer.
Protocol 40, overdose and tox.
For 2026, we tried to streamline the antidote table that was added last year.
The table still includes all the WVMS medications that might be useful in overdosing or poisoning.
Bolded indications are our typical standing orders,
like Versed for seizures or atropine for bradycardia.
But the rest of the antidotes and the indications are online orders only.
Providers are encouraged to call poison control or the ED for orders and dosing instructions for any of these more uncommon toxidromes.
For example, consider asymptomatic organophosphate poisoning.
Providers are expected to provide regular atropine doses for any symptomatic bradycardia without calling for orders.
But providers could also call poison control for orders to go above and beyond regular atropine dosing for other serious symptoms like bronchospasm or vomiting, etc.
Protocol number 50, neonate, has also been updated to match the American Heart Association 2025 neonatal guidelines.
Providers may try 30 seconds of ventilations for newborns with bradycardia before starting chest compressions.
Providers are also encouraged to use a T-piece resuscitator instead of a bag valve mask if available. Western Virginia EMS is asking to have disposable T-piece resuscitators included in the regional hospital exchange policy.
Providers may still use a neonatal BVM if a T-piece resuscitator is not available.
For protocol number 60, immobilization, some astute providers may have read the new spine trauma recommendations published this fall by the National Association of EMS Physicians and Virginia Office of EMS. They suggest C-collars may cause unnecessary harm and actually suggest removing them completely from EMS use.
We reviewed this with our trauma centers and neurosurgeons, and they are not quite ready to totally abandon C-collars.
We'll keep our minds open and we'll follow the discussion and science closely as it develops. But for 2026, there is no change to the SMR protocol. Providers are expected to continue using C-collars for now. The new NAMSP trauma recommendations also suggest pelvic binders may be less beneficial than previously thought.
Providers are reminded to check pelvic stability only once with gentle compression. And if you choose to place a pelvic binder, make sure it is over the trochanters and well below the belt line.
Improperly placed binders may cause more harm than good.
And now, a few updates for AEMTs and above. Other BLS providers, feel free to skip ahead. The AHA 2025 ACLS update suggests to start all cardioversion at 200 joules for adults.
The AHA 2025 PALS update continues to suggest starting lower for children and escalating doses as needed.
As always, PEDS dosing can be found in the PEDS reference section in the back.
We also endorse trying regular defibrillation if the monitor is unable to sync for cardioversion. We've also updated amnio drips to adults only.
In number 18, hyperkalemia, the bicarb pendulum has swung back in favor of pre-hospital use.
Providers may once again try bicarb for wide QRS on EKG or if acidosis is suspected.
For number 20, our pain protocol, we have some exciting new changes.
Pain has been updated to include Toradol.
This gives providers another option for intravenous non-narcotic pain control.
Toradol is an effective NSAID without major risk of oversedation or respiratory depression. Standard dosing is 15 milligrams IV, IO, IM, or IN for moderate pain. Toradol is a new medication, so if you're unfamiliar or have any questions, please contact your training officer.
Also in the pain protocol, the dosing of fentanyl has been expanded to a range, targeted best guess weight estimation dose of 0.5 to 1 microgram per kilo.
But we recognize weight estimation is fraught with error, especially in the pre-hospital environment.
Providers are encouraged to start with a lower dose for small and frail patients that are narcotic naive.
And consider higher doses for larger patients with serious pain.
In protocol number 30, dyspnea, we continue to encourage use of EpiNeb.
Remember, our EpiNebs are especially useful for any adult in extremis, such as anaphylaxis, or in pediatric patients, especially with croup or asthma.
Providers can also use a one-way valve adapter to give it in line with NIPPV. EpiNeb is an OEMS red dot skill, so if you have any questions or you're a new provider, contact your training officer.
Also backed by popular demand, magnesium is included in the small text for dyspnea. Mag may be helpful for status asthmaticus and or severe wheezing.
The dose for dyspnea is 1 gram slow IV over about 10 minutes.
But remember, VA OEMS mandates ALS monitoring for any patient receiving magnesium.
Protocol number 42, seizure, Versed has also been updated with range dosing.
Providers may elect to start with 2.5 to 5 of Versed per dose.
Like with fentanyl, consider lower doses for smaller or frail patients and larger doses for big patients or if using it intramuscular.
Note the max dose of Versed remains 10 milligrams total.
Providers will note protocol number 46 has been renamed to behavioral.
This was in recognition of some behavioral problems that are not psychiatric in nature. Versed is also updated here with range dosing to match the seizure dosing.
Providers are reminded about the importance of de-escalation.
Medication should only be used to increase patient safety,
and only when the benefit outweighs the risks.
Behavioral medications are an OEMS red dot skill.
So if you have any questions or you're a new provider, contact your training officer. 2 updates in the small text in protocol number 56, major trauma.
Providers should meticulously avoid hypotension for any obvious head or spine injury,
or if the patient is pregnant. Target a systolic blood pressure of at least 110 if you have any serious suspicions. Providers should only consider a lower systolic target around 90 if the chances of serious head or spine injury are low and the patient is not pregnant. Providers may also provide ANSEF despite a penicillin allergy, but should monitor for any potential reaction.
The chances of a cross-reaction are very small, and early antibiotics play an important role in major wounds.
So, if a major trauma patient has a significant open wound or an open fracture, please consider giving ANSEF.
The AHA 2025 PALS update endorses a third level of defib energy for pediatrics, so the PEDS reference has been updated with a third energy level of 10 joules per kilogram.
Providers are encouraged to escalate to this higher dose for the third and subsequent defib attempts.
Please note the maximum energy dose for all peds and adults is 200 joules. Lastly, we'll finish up with some reminders about the critical care program.
Critical care is meant for agencies that can commit to the increased time and expense required for training, oversight, equipment, and supplies. Providers are encouraged to reach out to their agency administration for more information.
Critical care protocols are for specifically trained and credentialed paramedics only.
And all critical care providers must be cleared by your agency and maintain all prerequisites. There are 2 new critical care protocols included in 2026, including hypertonic 3% saline and Keppra for elevated ICP.
And then there's also high-dose nitro drip and Lasix for pulmonary edema. Many of the interventions in critical care are OEMS red dot skills. The required training and documentation are covered in the yearly in-service training.
Regional in-service trainings are ongoing. If you are an interested agency, you should reach out to the Western Virginia EMS office
for more information and free examples of in-service programs.
So that's it. Congratulations on making it through another year rollout video. If you'd like to get more involved with the protocol process, we encourage you to discuss it with your training officer.
And consider joining the regional EMS protocol work group, where we review every change to every protocol every year. We also encourage any agency that's interested in critical care collaboration to reach out for example programs.
And so to finish this process, you should
download and print the attestation.
You can find the link below to download and print this.
Sign it and turn it into your training officer.
And wait to be formally released to start using the new 2026 version. As always, thank you all for your time and dedication. We are looking forward to this new year, and we will see you all again in January 2027.